صباح الخير يا جماعة. بسم الله الرحمن الرحيم. This is to report a case of rare post-LASIK complication. I will take a minute to discuss the history of refractive surgery. First of all, the case was performed here at the Mashriq Eye Center. The history of refractive surgery in Egypt. This is Dr. Ahmed Aziz, my father, Dr. Mustafa Qiri. They were one of the first refractive surgeons to perform PRK operations back in the 90s. It was the Summit 60, I think, laser machine. Their fear was not post-LASIK ectasia or buttonhole or free cap. Their fear was of the corneal melting after LASIK operation in the cases having connective tissue disease, systemic lupus, or whatever. This is a picture of corneal melting and DLK. Now to our case. 6 months ago, one of my relatives came to our facility to perform LASIK operation. He was myope, -3, -375. He never used glasses before. I wasn't satisfied because the uncorrected vision was 0.3. Somehow I wasn't satisfied, so I decided to postpone the case to do cycloplegic refraction, and it was postponed for a week. This was the pentacam, nothing suspicious. On the 20th, he did the uneventful LASIK operation. I had only one comment. I said I wouldn't be surprised if tomorrow he had a mild DLK because he had some extra meibomian secretions. The patient was very satisfied that night. He could actually see the score watching the World Cup matches. This was the first time he was very satisfied. He woke up 3 a.m., severe pain, put all of the eye drops from out of panic, and came in the morning with this picture. This picture, for me, it was the first time to see something like that. First day post-operative. I've been performing LASIK operations for almost 10 years, and I've seen thousands of follow-up cases of my professors. So this was the first time to see something like that. Severe pain, photophobia, lacrimation. Forcefully, I opened the eye to see this picture. Crescent of infiltrate and this small part of infiltrate. This is the right eye. You find it here from the punctum. And this is the left eye. It's almost a mirror image, or it's the same, unexplained. This is the picture of the slit lamp. You see this infiltrate. And the central cornea is almost clear. This is an important issue I'm going to illustrate later on. The vision was almost 6/6 or better. This is something I could not explain. The first thing, call for help. What is this? I called almost everybody. All my professors, all my colleagues, all my experienced colleagues. It was debatable. Some of them said this is infection, and right now use fortified antibiotics. Although this came from my professor's opinion, but I wasn't convinced. What kind of infection would do almost symmetrical bilateral infiltrate? Okay, it could be infection, but I'm not with it. It might be some sort of immune response. I decided to give antibiotics extra hourly and steroids extra hourly, and an injection of fortacortine this day, the first day. The second day, the patient came with this almost 360, also bilateral, also symmetrical. and actually I was very frustrated. The pain was a little bit the same, more or less. But you can see here, but it's not that clear, there is an area of DLK, there is developed DLK. So then the cercinate infiltrate and DLK. I called for help again. One of the things that I want to illustrate and thank Dr. Tamer Ragel for, he reassured me by phone. He asked me one question: is the infiltrate confined to the flap, or there is outside the flap edge? So I just followed again, take a screenshot and illustrated for him. I'm definite this is outside the flap. This is outside the flap. As you can see here, the DLK is evident. And again, I would like to thank Dr. Iyad Fahmi because he reassured me. He told me, since there is DLK, I am very confident. Don't worry, it is not infection and it's going to pass, inshallah. But I was not that confident because as you see this area of, I say, ulceration, thinning, melting, I don't know what it is. So I wasn't that confident. I thought this is going to develop to corneal melting. Same treatment, another injection of steroids. This is the on the slit lamp view. I would like to take this slide to discuss something I have been recognizing the past couple of months. The Chanflug image in the Pentacam can be used to first diagnose subclinical DLK and to follow up the improvement. Although you could see the slit lamp image, it is better, but this is something evident you can have if you just take the same cut and same view and follow up. This is one eye, this is the other. As you can see, there is the DLK, this is the flap, and there is this whitening reflection. So this is more or less severe DLK. Afterwards, it was better. Most probably I try to choose the same cut. Better. And here it is almost, as you see, gone. So the Chanflug image can be used to diagnose first the subclinical DLK and to follow up the improvement. This is a very important issue. This severe DLK here, you can see, this is the infiltrate, of course, this is the infiltrate, all white cornea. This is the DLK. You can see it in the interface between the flap and the rest of the cornea. Okay? Definitely, it is important, but it is much more expensive and it needs authorization to be done for research because this is something important. Okay? Bad memories. Anyway, back to our presentation. So here it is totally clear. It's not totally clear. If you can just magnify, it is very faint. This is what I'm calling about. Maybe if I took a picture for the patient the first day, I would have seen something like that. But it was only panic the first day. Okay, the final outcome after 2 months, the vision has improved again, and the peripheral infiltrate has been fading, but it never gone. This is the final outcome. If you can see, what's the difference between this image and this image? This is the second day. Of course, the infiltrate is denser, and there is this injection and severe pain. So this is the final outcome. This is the final outcome. It is excellent outcome. Okay, and this is the topography, flattening and thinning according to the myopic ablation, not extra, nothing extra happened. This is the important issue that I'm talking about, the OCT, I call this case not only peripheral ulcerative keratitis post-LASIK. No, I would like to call it and thinning too. Peripheral ulcerative keratitis and thinning. If you can see, it is extremely obvious that the periphery of the cornea is thinned. Actually, the normal cornea is thicker at the periphery, and the ablation profile of any myopic patient is more in the center. So I have no explanation to see this except there is thinning happened in this case. And this is one eye, this is the other eye. It is obvious. I don't have another explanation.
PUK, اللي هو principle for ulcerative
Keratitis following, yes, and thinning, scarring and thinning. There have been several cases published, I think 6 or 7, one in Korea. I think it is more or less similar to my case. Another case here. Third case.
أنا قصدك الليزك triggering القصة دي؟
No, it's not. It's immune response. Maybe these patients have some sort of underlying connective tissue disease. My relative, he didn't have anything except of some stomach ache for a couple of months. Maybe he would be diagnosed later on of ulcerative colitis. I don't know. And this is a twin brother following PRK at Saudi Arabia, almost the same. To my knowledge, this is the first case to be reported in Egypt. I asked, I called for help. I told you almost I called everybody, but nobody has seen something like this before. So to my knowledge, this is the first case to be reported in Egypt. Thank you, Dr. Nawar, for supporting me and authorizing the OCT scans for the case. Thank you.
حد عنده أسئلة يعني؟
علينا؟ طيب
حد عنده
هو الحالة بتاعتك did not reported